Okay, so we'll move on to the next session. Thanks, everyone. Good morning. Wonderful meeting. Great to see everyone here. My name's Martin Voss. I'm a geomedical oncologist at Memorial Sloan Kettering Cancer Center in New York. And for this session, I am joined here by my co-chair, Andrew Furness, with the Royal Marsden. And we have a wonderful lineup of speakers talking about novel targets in RCC, going sort of from bench to bedside, speaking about what's new to come. And we are going to kick off with David Braun, who's here with us from Yale Cancer Center and runs very successfully a lab there, and is going to talk to us about novel targets given perspective from a lab investigator. Thanks, Dave.
Thank you so much for the opportunity to speak to the organizers and to everyone for having me in this beautiful city. So today I'm going to speak about novel targets in RCC, really talking about some of the things that has come out of our lab and our collaborations over the last couple of years. Of course, it's impossible to be comprehensive in 10 minutes, but I'll try to give a little bit of a highlight of some of the things that I'm excited about, including some early things which have begun to make their way to the clinic. And so for today, hoping that I'll be able to provide a little bit of an understanding of some of the novel immunotherapy targets in kidney cancer, and focus a little bit on antigen-directed therapies, which I know John will then talk about in depth. And so really the guiding light for our lab is this cancer immunity cycle defined by Chen and Melman. Now this is really focused on CD8 T-cell mediated anti-tumor immunity, but for us provides a really good framework for how to think about where we might be able to intervene in order to improve immunotherapy coming from the lab and ultimately applying it to the bedside. And so what I want to talk about today is a couple of stories from our lab that focus on different elements of this cancer immunity cycle. First, I want to focus on that last step, which is how to effectively kill cancer cells, how to be phenotypically competent as CD8 T cells to kill cancer cells within the tumor microenvironment, and how we might go about identifying targets. And so this is work that was really done in collaboration with Mike Atkins as part of his HCRN GU16260 trial, which we heard a little bit about. It was a trial of first-line single-agent anti-PD-1 therapy in kidney cancer, nivolumab. It had a separate part, which was an attempt to salvage with ipilimumab for those that didn't respond, but we really focused on the anti-PD-1 monotherapy arm. And we were able to build into that a lot of sample collection of whole exome sequencing, bulk RNA sequencing, but what I want to talk about today is the single-cell RNA sequencing and T-cell receptor sequencing. For a subset of patients, we could collect fresh tumors either prior to treatment or at resistance or both, and perform single-cell RNA sequencing, which is what's shown here, where each dot represents one cell, and we could really get broad representation of cells across the tumor microenvironment. And so if we focus in on the T cells specifically, we see, as expected, a very rich T cell infiltration. We see lots of different T cell phenotypes. And so we did something relatively simple. We went for each T cell population, defined here or shown here by a different color, we asked, is it significantly associated with altered response? And that's on the x-axis. Or is it associated with altered survival? And that's on the y-axis. And we see there was only one T cell population, a CD8 T cell population with markers of exhaustion, so expression transcription factor tox, lots of inhibitory checkpoints like PD-1, TIM3, LAG3. It wasn't seemingly a total lack of function. It had expression of granzymes and cytokines, but it looked like it was a truly exhausted population. Interestingly, it expressed a couple of other markers that I associate with either innate-like behavior or tissue residency, things like ZNF6A3 or Hobbit, but also this homotypic receptor, SLAMF7, which we hadn't really seen in our T cell populations previously. And so it turns out this particular T cell population in this very small group was heavily associated with worse outcomes, both enriched in progressive disease, but also associated with much worse progression-free survival. And so what we did was create a signature, a gene expression signature representing this T cell population, and we applied that signature to the bulk setting. And what we could see in these independent or external cohorts is that in the bulk setting, this really was associated with resistance to anti-PD-1 monotherapy, but not with just a generally poor outcome. It didn't have really any effect in mTOR inhibition. And so this was a T cell population we think might be a marker of resistance to anti-PD-1 therapy. The question actually is this just a marker, or is there some functional role these T cells are playing? And so that's a difficult question, one that we're still in the early days of teasing apart in the lab. But as our first sort of attempt at this, what we did was look at SLAMF7, because we really hadn't seen that much in CD8 T cells before. We typically think of it in NK cells. And so for SLAMF7, what we did was overexpress it in healthy donor T cells. It's a homotypic receptor, it binds to itself, so we provided the ligand, SLAMF7 ligand with K562 cells. And what we saw was that SLAMF7 really directly impaired T cell function. It decreased CD8 and CD4 T cell proliferation. And also when we look at markers of T cell function, like the ability to produce cytokines or cytotoxic molecules like granzyme, it decreased those as well. And so we really think this is not the end of the story, it's sort of the beginning, but we really think SLAMF7, which is a receptor on many cells, but including CD8 T cells, really might be a potential therapeutic target and something that we're looking at now more deeply in the lab. So that's towards the end of the cycle, killing of cancer cells. I want to go back to the beginning, which is how we can get effective antigen responses. And what are the antigens we really should be targeting in kidney cancer? And so I came from Kathy Wu's lab. She studied neoantigens, so that was a natural place for me to start. So I think many people are familiar with neoantigens, but just in case, they are antigens that arise from mutations within the tumor cells, typically either small insertions and deletions or single nucleotide variants. And we show that here, which is the wild-type protein is not recognized by the T cells, but we have central tolerance to prevent that. But in the case of mutation, it's essentially a foreign epitope and one that can now be recognized by the T cells. And so when we started to look at this, David McDermott had looked at it in 2018, we looked at it in 2020, we really didn't see any association between tumor mutation burden or neoantigens and response to immune checkpoint inhibitors. So we were a little discouraged at first that neoantigens might not really be a target in kidney cancer like it is in melanoma and other tumor types. But I don't think that's true. I think we've had some more recent work which really show that particular types of neoantigens, in this case they show clonal neoantigens, really playing a role in exceptional response to immunotherapy. And so it gave us a little bit more confidence that these might really represent a true target within kidney cancer. And so it's with this that we launched a phase 1 trial of neoantigen targeting personalized cancer vaccine for patients who had fully resected stage 3 or stage 4 clear cell kidney cancer. This was an enormous collaborative effort with Kathy Wu and Patrick Ott, Darren Keskin, Tony Schwery, many, many others. So really a huge team effort. And so what we did was predict for each individual patient based on their mutations, which are the most likely to be effective antigens. We synthesized a custom vaccine for each patient and delivered it in this prime boost format. And so we had a lot of basic questions. This was really a first in disease study for this multi-epitope neoantigen vaccine. Can we do this for kidney cancer? It's not melanoma, it has a very modest mutation burden. And the short answer is yes. For every single patient, it was 9 patients on the study, we were able to successfully manufacture a vaccine, on average about 15 neoantigen-containing peptides per patient, despite a low mutation burden. The next question is, could we actually elicit an immune response? And this is a lot of data summarized in this heat map, but it's basically a series of interferon gamma LE spots, where before vaccination, during vaccination, and afterwards, we assessed whether the circulating T cells were capable of recognizing those neoantigens. And we started all the way on the left-hand side. We could see it's basically that column is white, meaning there were no pre-existing responses that we could detect, at least, against these neoantigens. But as you move from left to right, for every single patient, we were able to detect an immune response. So this really was an immunogenic vaccine in all of these 9 patients. If we look at what were the actual targets, we actually saw that some of these clonal neoantigens, particularly from driver mutations, really had elicited potent immune responses. I'm showing one example of VHL mutant peptide, which each of those dots represent one T cell response, and the strength of that response was as strong as really the positive control. So some of these responses against these clonal neoantigens derived from driver mutations were incredibly potent. Next were these immune responses actually durable? So we identified vaccine-specific T cell receptors, and we were able to track those in the blood, and that's shown in this curve in red. So at the beginning, they're basically sub-detectable, and then we see it shoots up the red curve with vaccination, but it actually stays up for months and even years after finishing vaccination. So this is really eliciting a durable T-cell response. And then, of course, is that response actually capable of eliciting an anti-tumor effect? So we would take those T cells that were induced post-vaccination, we would expand them and put them on top of that patient's own tumor that we had kept cryopreserved to detect whether it was capable of anti-tumor responses. And the answer was yes, not for all patients, but for 7 of 9 patients, we could actually detect an anti-tumor response. Last is, how did those patients do? And I'm always hesitant about this part because there's only 9 patients, and so those 9 patients might have been cured by surgery alone, but I think reassuringly those 9 patients all did well. None of them had a recurrence of their cancer. And so this was at least part of the motivation, that and work coming from melanoma, that led to the phase 2 trial, the InterPath 004, which is now fully accrued, and we're going to be awaiting results in the coming years. Very quickly, I'll just mention neoantigens I think are a promising target, but they're not the only ones. I'll go back to kidney cancer being a modest mutation burden tumor. There are other targets as well, and in 10 seconds, I'll just highlight endogenous retroviruses, viruses that are dormant within all of our bodies but can become reawakened in kidney cancer, represent a new antigen type as well. This is work led by Chin-Chin Zhang in Bill Kalin's lab, a wonderful collaboration with Bill, with Kathy Wu, Steve Carr, where we could identify that there's a series of HIF2 regulated endogenous retroviruses in kidney cancer, that they are transcribed, they're translated into protein, and actually presented on the surface of tumor cells on their HLA class 1 molecules. We can detect that they actually elicit T-cell responses in RCC patients. And in a naive setting, in this case using a transgenic mouse, HLA transgenic mouse, we can actually induce vaccine-inducible responses against these endogenous retroviruses. And so we really think that this might represent a new class of antigens as we think of the next generation of vaccines. And so with that, a couple of important take-homes. One is that CD8 T-cell phenotype is incredibly important for understanding response to our current immune checkpoint inhibitors, and that hopefully we're seeing the beginning of an era of really antigen-directed therapies that can steer the immune system towards the tumor. And so with that, lots of people to thank, but mostly the patients and their families. So thank you so much.
Thanks, David. That was fantastic. So we'll head straight on to John, please, to talk about vaccines and novel cell therapies.
Thank you very much for the kind invitation to speak here today on vaccines and novel cell therapies. My name is John Hahn. I'm from the Netherlands Cancer Institute. So is there a role for vaccines in kidney cancer, and is the promise of cell therapy that we know seen in especially hematologic malignancies also justifies in RCC. And of course, if we look back at decades of trying to make therapeutic vaccines, the answer is that so far we have failed, right? And that was also true, I think, in kidney cancer. The only vaccine that has been FDA approved was Hypoleucel T for patients with prostate cancer, but also there the landscape of treatments has changed so much that we're currently not using that anymore. When we look at vaccines in kidney cancer, we can go back to quite a long time, and one of the first vaccines that was exclusively was tested rigorously was the 5T4, an oncofetal protein which is almost exclusively expressed in cancers, including kidney cancer, and it plays a role in motility, in invasion, and EMT. It's a vaccine that was made of a MVA, so it's a modified vaccinia virus expressing 5T4 to induce CD8 T-cell responses against that particular antigen. And the phase 2 study led to the induction of immune responses, and of course that's always very important, and perhaps some signal of survival benefit in good and intermediate risk kidney cancer patients. However, a phase 3 trial, the TRIST study, including 700 patients randomized to standard of care IL-2 interferon plus or minus Trovax, did not show any overall survival benefit. And perhaps this was already the idea that we should probably not try to treat patients really with end-stage disease with these kind of vaccines. Another vaccine that has been tested was the carbonic anhydrase 9 targeted vaccines, mostly peptide vaccines, combined with poly-ICLC, which really leads as an adjuvant to the induction of a good immune response. Of course, we have dendritic cell vaccines, antibody vaccine conjugates have been tried, all in small phase 1-2 clinical trials, where immunological activity was seen, but no significant anti-tumor regression as a single agent. So, quite disappointing. Then we have the AGS-003, rocapildan cell T. It's an autologous dendritic cell vaccine, electroporated with a tumor RNA and CD40 ligand mRNA. It's in a phase 2 study in combination with sunitinib in kidney cancer. The overall survival was 30.2 months. However, a randomized phase 3 trial, the ADEPT trial, there the primary endpoint, which was overall survival, was not met. Responders, however, did show some improved long-term survival. So oftentimes we do see that in a subgroup of patients, they may benefit from a vaccine, but overall the effect was quite disappointing. We have tumor lysate pulsed DC vaccines, autologous dendritic cell vaccines, that led to the induction of responses, but no clinical effects. Combined DC vaccine plus cytokine support. There was a phase 1-2 clinical trial of a DC pulse with multiple peptides, either coming from carbonic anhydrase 9 or survivin, combined with OK432, which is in fact a lyophilized mixture of Streptococcus pyogenes, so therefore a kind of adjuvant combined with interleukin-2. Some of these patients showed a partial response and T-cell activation, but again, very little clinical efficacy. And then, when that's something that we just heard from David, the personalized cancer vaccines, and there is quite a lot of promise in trials coming from patients with melanoma, but also in other cancer types like pancreatic cancer, where especially mRNA vaccines encoding multiple new antigens can really lead in the adjuvant setting, so in minimal residual disease situation, in combination with checkpoint blockade, lead to a difference in relapse-free survival and also distant metastasis-free survival. Whether that translates to an overall survival difference, that is something that we still have to await. And currently, many phase 3 trials and also phase 2 trials are ongoing with personalized cancer vaccines encoding multiple neoantigens. In kidney cancer, we have the VHL neopeptide vaccine in advanced kidney cancer, again in late-stage disease, which induced immune responses. And then we heard the data that was just presented by David, a multiple neoantigen peptide vaccines, including peptides from VHL, PBM1, PEP1, PIK3CA, etc., in high-risk patients or in metastatic disease. And in phase 1 study, this was given by the intradermal injections. There's promising outcomes with disease-free survival. We do see induced neoantigen reactive responses, and the treatment was well tolerated, but it was only shown in 9 patients, and of course we don't know whether this really is efficacious in a larger patient population, and therefore there are a couple of larger trials currently ongoing, and David already mentioned the Interpath 004 study, a randomized phase 2 study of pembrolizumab, plus this mRNA vaccine encoding multiple neoantigens or placebo as adjuvant for high-risk clear cell carcinoma. And then there's the P-neo-VCA, a combination of cyclophosphamide plus a personalized peptide vaccine and pembrolizumab for advanced stage clear cell RCC. So now let's switch to cell therapies for kidney cancer. Also there are a couple of targets that have been tried. Carbonic anhydrase 9, I will mention this a little bit more, CD70, especially allogeneic CAR T cells. Then of course we can target one of the other classes of antigens, the endogenous retroviral elements, using a T cell receptor, gene-modified T cell population, and there may be other targets as well, and we can shortly discuss also TIL. When we look at carbonic anhydrase CAR T cells, I think one of the first trials ever performed with a CAR T cell was performed in kidney cancer in the Netherlands by a group in Rotterdam. And they used a first-generation CAR T cell, so there was no co-stim there, and no lymphodepletion was given. Of course, we know that carbonic anhydrase is highly expressed in kidney cancer, but unfortunately, it's also expressed in bile duct epithelia. So in this trial, patients received multiple infusions, but the trial had to be stopped because of grade 2 to 3 liver toxicity. And also important to mention that there were no clinical responses. What was required by the regulatory authorities to treat these patients prior to infusion of CAR T cells with the antibody targeting, the antibody G250. Of course, if you do that, you block all the carbonic anhydrase 9 on both tumor cells and also the bile ducts, so you don't see toxicity, but also no efficacy. There are currently quite a number of trials with a CAR T cell targeting carbonic anhydrase 9 ongoing in China, and of course we have to wait the results of these trials. What about CD17 CAR T cells? And there are quite a number of allogeneic CAR T cells trials ongoing. We and others participated in a trial by CRISPR Therapeutics, the CTX130 trial, which was a second generation 4-1BB co-stimulation containing CAR, where not only the TRAC locus, so the T cell receptor, endogenous T cell receptor locus was knocked out, but also better to microglobulins. You have to remember that these are allogeneic T cells, and therefore they may induce a very rapid immune response against them. And also CD70 was knocked out in order to prevent fratricide, so that the T cells kill themselves. And there was a knock-in, of course, of the CD70 CAR. In a clinical trial called the COBALT trial in patients with metastatic clear cell RCC with high expression of CD70, 16 patients were included. They all received one or more infusions. Some patients were treated more than once with CTX130. And following lymphodepleting chemotherapy, the CAR T cells were infused. CRS was seen, very low grades, 1 to 2, manageable, no icons, no graft-versus-host disease, low objective response rate of 6%, but a large number of patients had some disease stabilization. The cells expanded very early, between day 7 and 14, but were undetectable already at day 28, which may have be a problem. And trials are currently ongoing with Allogene, also a trial with BMS, and in China. So the last, one of the last slides is targeting HERV-E, and also there we have a peptide which can bind to HLA-A2 and therefore can be targeted by a T cell receptor specific for this peptide MHC combination. And autologous T cells have been transduced with the TCR, and 19 patients were selected to be HLA-A11 positive, and following lymphodepleting chemotherapy, infusion of this TCR T cells and interleukin-2 administration, 17 patients were included in this phase 1 dose escalation study. No new safety issues, a partial response rate of 7%, and a disease control rate, a stable disease of 29%. So there are some data on TIL, but not many, only preclinical data where it's possible to grow TIL from RCC, either from metastatic lesions or from the primary. The cells seem to have, at least by CD3, CD28 beat stimulation, some production of interferon gamma and granzyme B, and there are several trials ongoing with TIL in RCC, but it's too early to see any responses. So what are my take-home messages? Cancer vaccines, and especially personalized vaccines, are in development for RCC, especially in the adjuvant setting, I would say, and we will learn more in the next 1 or 2 years. Cell therapies targeting CD70 and perhaps still could become novel treatment strategies in the near future, but of course we need more data to be more convinced that this is a way forward. Thank you very much for your attention.
Thanks, John. That was fantastic. And next we have Andrew talking to us about perspectives from melanoma.
Thanks very much. So in terms of sort of what to cover today, I was keen to go through timing of therapy. There will be some repetition in terms of the perioperative data that you listened to yesterday, but perhaps a few extra comments or considerations. Potential de-escalation of therapy, sequencing, mainly in the metastatic setting, approaches in checkpoint inhibitor resistance, which is obviously a huge problem in melanoma and kidney cancer, and then this sort of holy grail of trying to achieve therapeutic synergy and where we are in the melanoma world from that perspective. So I think this data will have been presented yesterday. It was the SWOG S1801 study, And this is for patients with stage 3 melanoma. So these are patients who have palpable lymph nodes involved with melanoma. And within this trial, until recently, the standard of care here was to perform surgery and consider a year of adjuvant anti-PD-1 monotherapy. And very simply, within this trial, 3 cycles of pembrolizumab were given up front, then patients had surgery and completed their adjuvant therapy. And you can see the difference in efficacy here in terms of event-free survival. More recently, we've had the NADINA study from Christian Blank and colleagues at the NKI using a Nivo-IPI up front, as an IPI light dose or renal dose of IPI, and demonstrating the utility of giving 2 cycles of that in the neoadjuvant setting, and that patients do better in this context than receiving surgery and adjuvant therapy. But I think more than that, what this study demonstrated was the potential to de-escalate therapy. And so leading up to this, there'd been a couple of other neoadjuvant studies that really informed NADINA. And from this, so patients who had 2 cycles of ipi-nivo had a major pathological response defined as less than or equal to 10% remaining tumour cells within the surgical specimen. Those patients could safely de-escalate and receive no adjuvant therapy, sparing toxicity, sparing financial toxicity, etc. So I think that's really encouraging. What we don't really have as an answer, though, is what to do with the patients that develop a partial pathological response, or particularly pathological non-response. Should those patients be carrying on with adjuvant therapy? And that's still a sort of unknown question. And within the neoadjuvant studies that preceded NADINA, Opus in Neo and Prado, a number of questions were sought to be answered, not just questions about should adjuvant therapy continue and what should it be, but also in terms of the extent of surgery, could potentially morbid lymph node dissections be spared? And so this was a huge effort, and I think much of the kidney cancer community think that if we can learn lessons from these very cleverly designed academic studies. This was the Opus in Neo trial and Prado trial, and I won't have sort of time to go through this now, but I just wanted to highlight this data. I think the first thing to highlight, though, is that it's small numbers if you look at the bottom. But this is looking at relapse-free survival and distant metastasis-free survival amongst patients who had a pathological non-response, so no clear evidence of neoadjuvant treatment. And it would look, when you look at this data, that for them there is a benefit of carrying on the adjuvant systemic therapy. But as I say, small numbers, it's difficult to explain that. One of the arguments for the benefit of, or the potential benefit of introducing neoadjuvant therapy, which is just a hypothesis, is you have slightly more tumor volume. Is that more immunogenic, in addition to having regional normal lymph node tissue sort of in situ? Here the arguments people sometimes give is that maybe there's a differential sensitivity of microscopic disease to macroscopic, but that's just sort of contradictory to the argument for giving the neoadjuvant. So I think we need more data in that space, and I'm sure it will come. But it is, as you can imagine, quite difficult to discuss with a patient who's seemingly progressed through neoadjuvant treatment, or progressed through adjuvant treatment, no evidence of pathological response to suggest that, yeah, you should go on and finish your year of adjuvant therapy. So I think that's an important question to answer. Moving to the advanced disease setting, this is a DREAMseq study in melanoma, trying to understand what should be given first, what leads to best outcomes, regardless of whether you go on and have long-term cancer control or not. And so most of you know that in melanoma we have ipi-nivo as most often, or one of our favored first-line therapies. And for about half of our patients whose melanoma harbors a BRAF mutation, we have so-called targeted therapies, small molecule inhibitors of mutant BRAF, and we give MEK inhibitors alongside these. And so what should be given first? And this trial sought to determine that. And so patients received either ipi-nivo first or dabrafenib and trametinib first, and switched over on progression if they progressed. And what this trial showed is that it is better, if you can, to start with ipilimumab and nivolumab and switch if needed, or rescue if needed. And I suppose in kidney cancer, we've had discussions this morning that we're still defining what is optimal to start. There are a group of people, as everybody in the room well knows, who think that if at all possible, you should start with pure immunotherapy, IO, and perhaps the addition of a TKI is actually not helpful from an anti-cancer immunity perspective. But I guess that story hasn't been fully reported. And this is probably more nuanced too. And I think in the melanoma world, we're trying to understand that maybe there is a role for some sort of initial debulking or in some scenarios, and then a switch to ipilimumab and nivolumab, for example. Particularly patients who are very symptomatic of their disease. Dabrafenib and trametinib targeted therapies are very effective. They work within hours, short days. And so we're still trying to understand how best to use those. But in many of our sort of public healthcare systems, we are limited. We can't switch between this treatment and that treatment at our will until there's better evidence base to support doing that. In terms of TIL therapy, I was obviously not going to add much to John's presentation, but I just wanted to make a general point, which is that kidney cancer, as we well know, is a very heterogeneous disease. And so it would be attractive from a cell therapy perspective, cell therapies which are typically directed against single antigens, to use a polyclonal approach like polyclonal TIL therapy. And in melanoma, we have FDA approval of lifileucel, a polyclonal TIL therapy for refractory melanoma, and we're hoping in the UK and Europe soon we will get approval to use that. There's more nuance to the kidney cancer setting. It's high-dose chemotherapy. How is that going to impact our patients? But there is the potential to adapt things. And in lung cancer, the TIL therapy trials consider that. They consider differently the dose of chemotherapies. They consider differently how much IL-2 you should be pushing for and that sort of thing. So we'll have to watch that space, as John said. Other approaches in the checkpoint inhibitor refractory setting, a lot of excitement and discussion around BiTEs, bispecifics, ImmTACs, and all of these more or less rely on this sort of principle that if you have a non-immunogenic tumor type or a tumor type that has sort of acquired resistance to checkpoint inhibition, then perhaps taking the brakes off pre-existing immune responses to with checkpoint inhibitors is not going to impact. These treatments seek to bring the immune system to the tumor and or activate relevant T cells. And in melanoma, we do have an example of this. So there's a subtype of melanoma that arises at the back of the eye, uveal melanoma. This is a non-immunogenic tumor type with a low tumor mutational burden that displays minimal or very limited sensitivity to checkpoint inhibitors. And tebentafusp is the first drug that's prolonged survival in that setting. The FUSP part of the title, or the word, stands for fusion protein. And so this has a targeting domain, which is an engineered T-cell receptor that recognizes a GP100 peptide expressed on HLA-A201 on top of the melanoma cell. The other end has the effector domain has an anti-CD3 component, so it binds to CD3, which is part of the T-cell receptor, and literally pulls T cells into the tumor. You can see, this is a slide from Immunocore, and you can see that they suggest on the left that this leads to T cells to lysing the cancer cell target. I think we don't know how these drugs work. In fact, response, objective response, shrinkage of tumors, we don't see with this sort of approach. If it works, it leads to stability, but that stability for those in whom it works can last for years. And so that's clinically meaningful. And I think in kidney cancer, although it's heterogeneous, I think because this potentially acts by impacting the cytokine milieu more broadly, it might be applicable to kidney cancer if we can find targets that are highly expressed, ubiquitously expressed across different anatomical sites. And just to finish, really, I think for a number of years I've been using this slide as a sort of educational perspective to see where we are in terms of what we really want to achieve, which is adding to checkpoint inhibition, getting therapeutic synergy. I think we have achieved this goal here of inducing or expanding neoantigen-specific T cells or in the context of polyclonal TIL therapy. So although we're not deliberately selecting neoantigen-reactive T cells with polyclonal TIL therapy, we are expanding them up in vitro, and then we are giving them back into the body. And in trials like the Iovance COM202 study, a first-line study with TIL therapy and pembrolizumab, there definitely does seem to be synergy across smallish numbers of patients, but response rates above 60%, CR rates above 30%, so that looks promising. This should be amber in the middle. It's really just to highlight in the vaccine space, we have a positive phase 2 study in melanoma in the adjuvant setting, mRNA vaccine plus pembrolizumab, but we need to see data in a large number of patients. And this is red as it should be. And I just wanted to highlight that still, I can't think of a situation where we have been able to reliably induce tumor cell destruction, for example, with targeted therapies in melanoma, and get synergy or clearly derive synergy with immunotherapy. It feels like it should be easier than it is. I don't think we have that with radiation. I don't think we have that with oncolytic virotherapy either. So still, a huge amount of work to do in that space to understand how we can derive that. And so just to finish, immunologically, it's obviously kidney cancer and melanoma are not, are very different diseases. There are some rules that apply to both: immune regulation, immune checkpoints regulating activated T cells. But clearly, kidney cancer is not melanoma, and those of us that treat both, see very different kinetics in the clinic and know things are different. And I think a number of the questions we need to answer specifically in kidney cancer also. But I think the neoadjuvant setting and the neoadjuvant data in melanoma is inspiring, just shows what you can achieve with clever trial design. The translational outputs I didn't cover at all from those neoadjuvant studies, but are promising in those sort of window studies where you can serially sample. And I think a number of those biomarkers that are being developed could potentially be more broadly applicable to the advanced setting as well. And then finally, the checkpoint inhibitor refractory space is still a difficult nut to crack, but as described, there are a number of novel strategies that look potentially promising. Thanks very much for listening.
Thank you, Andrew. That was terrific. And then last but not least, we have Cristina Suarez, who is a senior medical oncologist and leads RCC efforts at Valderon in Barcelona, and she's going to talk to us about novel targets in the non-immunotherapy space. Cristina.
Thank you, Martin. First of all, I would like to thank the KCA and congratulate them for organizing this great meeting, and also for giving me the opportunity to be part of the scientific committee. And I would also like to thank the rest of the scientific committee for being such an amazing group. Thank you, guys. So the objective of this talk is to dive into new non-immunotherapy therapies under investigation and to have a general idea of the ongoing trials and the possible future in the short or medium term. So although I'm going to talk about the future, I'm going to start talking about the present. And we are in celebration now because recently EMA approved belzutifan in Europe for 2 indications: patients with VHL disease and patients that have progressed to PD-1 and 2 TKIs. And this was based on these 2 trials. You all know this is the trial that gave the proof already in the FDA in patients with VHL disease, showing an overall response rate of 50% in RCC lesions with almost 100% in clinical benefit, but also overall response or good responses in other lesions such as pancreas, neuroendocrine tumors, or hemangioblastomas. And the other indication was achieved based on the LIGHTSPAR-005 trial. As you all know, the LIGHTSPAR-005 trial included patients that have already progressed to anti-PD-1 or anti-TKI inhibitors. Patients were randomized to receive belzutifan and everolimus, and the 005 trial demonstrated a benefit in overall response rate with nice duration of response and also in progression-free survival. As we will see, and we have always been seeing with HIF-2α inhibitors, the most common adverse events were anemia and fatigue. But belzutifan has also been tested in combination with other drugs, as it's a very well-tolerated drug. So we have the 003 trial in combination with cabozantinib. We had the cohort 1 patients in first line. The overall response rate was 70%, reaching 79% in favorable risk, and cohort 2 in pretreated patients with 31% of overall response rate. Another interesting trial, the Umbrella 03B trial, explored different combinations of different targets, but the arm with belzutifan plus lenvatinib reached an overall response rate of 50%. And this combination, belzutifan plus lenvatinib, is being explored or has been explored because the recruitment of the trial was closed 1.5 years ago. In the LIGHTSPAR-011 trial. So the LIGHTSPAR-011 trial is a phase 3 trial comparing belzutifan plus lenvatinib versus cabozantinib in pretreated patients. Belzutifan is also being explored in the adjuvant setting in combination with pembrolizumab in the LIGHTSPAR-022 trial, and also in first line in the LIGHTSPAR-012 trial in combination with lenvatinib, belzutifan, pembrolizumab, or another arm with quanlimumab. It's a combination of pembrolizumab and CTLA-4 against pem-lenvatinib. So these are the ongoing trials. All of them are already closed, so we are waiting for the results. But other companies are also exploring HIF-2 alpha inhibitors. This is a HIF-2 alpha inhibitor of Novartis, DFF332, that showed modest activity, and so we will see what happened with the development of this drug. In contrast, this drug, NAKT2152, is another HIF-2 alpha inhibitor showing promising results with 25% of partial response in a very pretreated population and an interesting PFS. Casdatifan is a new generation HIF-2 alpha inhibitor from another company, from Arcus, that showed really promising results with an overall response rate with a dose of 100 milligrams of 33%. And this drug, it's been explored in a phase 3 trial, in the PIG-1 trial, in patients that had already received anti-PD-1 or anti-PD-L1 inhibitors. So this will include patients first line, but also patients progressing to adjuvant pembrolizumab. And the PIG-1 trial is a phase 3 trial randomizing patients to casdatifan plus cabozantinib versus placebo plus cabozantinib. And the primary endpoint will be PFS. So we are very excited about this trial that will start soon. So the story with TKIs, it's not closed. So zanzalintinib is a novel multi-target TKI that inhibits kinases including VEGFR, MET, but also the TAM kinase family, which includes AXL and MER, and has a very short life, which makes this the toxicity more manageable. So we could call that a super cabozantinib. Is a new generation TKI. So this drug has been explored in the STELLAR-001 and STELLAR-002 trials. As you can see, they have multiple cohorts with different tumors, but some of them with RCC. And data from from expansion cohort of clear cell RCC from the STELLAR-001 trial were already presented. And as you can see, it showed really a good overall response rate, 38% in a very pretreated populations with a disease control rate of 88%. And these responses were regardless of prior cabozantinib. More common adverse events were, as we expected from a TKI, diarrhea, hypertension, or asthenia. So zanzalintinib is being explored in a phase 3 trial, the STELLAR-304 trial, in non-clear cell RCC in combination with nivolumab versus sunitinib. And this trial closed the recruitment last week, so we will have results in the not so long future, I hope. So, but iraxep is a recombinant fusion protein containing an extracellular region of AXL combined with a human immunoglobulin G1, and that drug was explored in three cohorts: in monotherapy, in first line with cabozantinib and nivolumab, and in pretreated patients in combination with nivolumab. For me, the most interesting data are in pretreated patients in combination with nivolumab, reaching an overall response rate of 36% and a clinical benefit of 72%. So now moving to girentuximab. As you know, carbonic anhydrase is a cell surface transmembrane protein induced by hypoxia, and we know that this the CA9, the RCC shows the highest expression of CA9. 90% of patients will express CA9. So we know that girentuximab is an antibody-based PET imaging agent targeting this CA9, and that already demonstrated its benefit in diagnosis. So girentuximab demonstrated to improve in a phase 3 trial the identification of clear cell RCC as compared to conventional images. But girentuximab can also be used in diagnosis, and so we have these two trials, phase 1 trial and phase 2 trial, in combination with lutetium girentuximab. Both trials demonstrated long-lasting stable disease, and in both trials we see that the most common toxicity was myelotoxicity. In fact, it was the dose-limiting toxicity in the phase 1 trial. So girentuximab is going to be explored in the Starlight 1 trial in first line in combination with cabozantinib and nivolumab, and in the Starlight 2 trial in pre-treated patients in combination with nivolumab. Ciforadenant is an immunocheckpoint inhibitor against adenosine A2A receptor, so it's an adenosine A2A receptor antagonist that was explored in a pretreated population in monotherapy and in combination with atezolizumab, that demonstrating some activity. It's going to be, is currently being investigated in combination with nivolumab plus ipilimumab. So, finally, PARP inhibitors. So what is the rationale to use PARP inhibitors in RCC? We know that hypoxia drives the development of genomic instability via downregulation of the DNA repair gene expression. And this DNA repair gene expression, we know that are downregulated by hypoxic stress and decreased in VHL deficient renal cells, this is in vitro data, as compared to normal or VHL normal cells. So this gene expression is associated with impaired DNA double-strand break repel. So this VHL deficiency confers the increased sensitivity to PARP inhibitors. And what would be the rationale to use PARP inhibitors in combination with immunotherapy? So we know that DNA damage repair can sensitize tumors to immunotherapy. In this trial, DDR were detected in almost 20% of the patients. Most common DDR were CHEK2 and ATM. And this DDR status was associated with superior overall survival for patients treated with immunotherapy with a hazard ratio of 0.41, whereas no association was seen with VEGF-R TKI treatment. But unfortunately, although all this nice rationale, the first phase 2 trial we have with talazoparib plus avelumab did not show any responses. There are many ongoing trials with PARP inhibitors in RCC, so we will need to wait for the results. And finally, just to mention that CDK inhibitors will also have a role in RCC, or will be exploring RCC, especially palbociclib in combination with belzutifan in the LIGHTSPARK-024 trial in pretreated patients, or in combination with axitinib and avelumab in first line. So, in conclusion, belzutifan is a new standard of care in RCC, and other HIF-2α inhibitors are under investigation with promising results. Other drugs with interesting targets are also under investigation, but we should focus our efforts on finding biomarkers that will help us to choose the most appropriate treatments for each patient. And my last take-home message is the best way of predicting the future is creating it, so we should include patients in clinical trials to generate the future and improve the future. Thank you very much.
Thanks very much, Christina. And we have 10 minutes for questions. So anyone in the audience, if you have questions, please come up to the microphone. Please go ahead.
Hi, thank you. This is Jesús García Donas from San Chinarro in Madrid. Professor Brown, regarding the presence of exhausted T cells in the tumor, do you think they are just T cells that are not working, or they can have some kind of active role enhancing the growth of tumor, something similar to into macrophages, something like that, or they are passive cells?
So that's an excellent question. I think the reality is we haven't explored its impact on other cell types. We really explored it in a T-cell intrinsic way, but it's a really nice idea to say, okay, is it not just hypofunctional on the T-cell front, but is it actually inducing either negative effects on other immune cells or on the tumor cell itself?
Another question for you and for Johan. When you select neoantigens for these personalized vaccines, do you just pick the most frequent antigen you find in the tumor? Do you also look at the HLA sequence? Do you sequence TCR? Because to have an immune response is difficult. How do you integrate all these elements?
I can tell you how we did for RCC, which was a bit of a learning process. So it was multi-step. We first made sure the mutation was high quality, so we actually manually reviewed each mutation. We made sure there was RNA level support of the variant as well, because some of these, especially indels, can undergo nonsense-mediated decay, so you don't actually get to protein. Then we used a couple of different algorithms to predict which, given that patient's specific HLA allelotypes, which were most likely to be binders, and we had a ranking system based on those two algorithms. And then we included a lot of what I would call soft factors, which we think probably play a role, but don't know for sure. Things like, what is the expression level, high expression being better? Was it a driver or a passenger? Was it a clonal mutation, a subclonal? All of those things sort of played a role at the edges in our selection. But that was just our RCC experience. I don't know elsewhere.
Yeah, so I think in the mRNA vaccine data, especially coming from melanoma patients, of course the tumors was sequenced, DNA sequenced, and also mRNA sequenced, and then based on the mutations and also the expression level of the mRNA, in this case 34 neoantigens were chosen that could bind to the HLA of the patient, and those were included in the vaccine. So there was absolutely no idea whether there were T cells in the patient that could recognize these. We don't even know whether the antigen is truly expressed by the tumor cells, right? So that's why they incorporated 34 of these antigens, and probably only a fraction of those will be truly presented by the tumor, and therefore could induce an immune response that is really meaningful for this disease. One thing I should mention, I think, in these trials, the control arm is placebo. I'm not 100% sure that placebo in this is the best control arm. One could argue that having an mRNA vaccine that doesn't encode any antigen could be a better control arm, but that's currently not included.
Terrific. Thank you. Laurence?
Yeah, thank you. I had a similar question about the antigen and the number, but thank you very much for covering that. It's fantastic session. So I'll have a question for Andrew now. The DREAM-seq trial that you presented shows us that obviously patients receiving IO first and then potentially subsequently the targeted therapy did better. But how much is that related to the lack of access to IO as a rescue strategy, so Nivo-EP? How many patients did not receive the second treatment in the TKI arm?
I don't know that data back to front, actually, Laurence, to answer that question. I mean, there's definitely some, you definitely lose some patients early on in the Ipi-Nivo arm, actually, who progress really badly through that. I think there's still some learning there. I think from a biological perspective, there's definitely some concern that the resistance that there can be overlapping mechanisms of resistance on targeted therapy, which will also apply to the immunotherapy setting. But I don't think it's as black and white as perhaps DREAM-seq suggested. And as I suggest, I think it's more nuanced. And if we could access whatever we want, whenever we want, and go back and forth, and be informed by things like changes in ctDNA and so on, I hope it will be, a bit like we've been saying about everything, it will be much more nuanced going forward.
Thank you. Thanks.
Gabriel?
Yeah, I have a question to David regarding the SLAM F7 population of CD8 cells. Can you please comment if you have crosstalk with other types of cells? Have you done any spatial data to show if they correlate with other types of population? It's creating a niche in the type of tumors that explain the immunosuppressive microenvironment. Thank you.
Yeah, it's a great question. So not the resolution I think we need to. We've done some basic Visium analysis, which is 55 micron, which is okay, and we don't see really discrete niches where these are present. We see some relationships between these and TLSs, like very marginally. I didn't show this part of the story. There's a TLS element as well here, which is TLSs, as was shown, is certainly associated with favorable responses. But if you have TLSs and these SLAM F7 cells, then all of a sudden you get essentially the same responses as if you had no TLSs themselves. So we think there might be a role there. We've looked at what are the other cell types that express SLAM F7. Certainly myeloid cells are the predominant contributors there. And so we suspect there might be sort of further myeloid T cell interactions as well.
Okay. And in the, I guess you have done cell chat or communication. There are any populations that's macrophage? Or?
Yeah, macrophages.
Probably.
That's the main one.
Okay, thank you very much.
Yep.
I think great session again to Dr. Braun. David, you showed the data following up on what Gabrielle mentioned, SLAM F7, the exhausted phenotype, but this is obviously in Nivo monotherapy treated patients, and we don't, in metastatic disease, treat patients with single agent anti-PD-1. So have you done any, or are you doing any ongoing work with Nivo-IPI, for example, to try to identify in a similar fashion what would be the target exhausted T cell?
Yeah, it's a great question because you're absolutely right. We don't use single agent anti-PD-1 therapy, though I would argue for these sort of scientific studies, it's nice to sort of look at the contribution of components and see what is the role specifically in anti-PD-1 resistance. I think when we've taken this signature, we've applied it to IO-TKI combinations, and we don't see a predictive effect there. And similar with TKIs alone. So I don't think this is going to be something where, for a TKI-based regimen, this is going to be predictive. The best thing would be for an IO-IO regimen. We don't have bulk RNA. Right now, it just doesn't exist. Checkmate 214 didn't have high-quality RNA that was sort of usable for this sort of signature assessment. So we have done some single cell, small numbers, and the short answer is we're definitely seeing a similar pattern, but not anything where we have the final analysis done yet.
I was going to suggest, Laurence can maybe comment on that. The 8YA study has, the randomized Nivo-IPI versus Nivo. That would be, if there is any tissue that you could use, that would be an opportunity, I think, to really look at validating in a larger trial the Nivo arm, and then also looking at Nivo-IPI. Martin, if you don't mind me asking Dr. Hanan a question. Monday morning, you have a patient with progressive disease, clear cell RCC, progressive disease through standard of care. You have at your NKI the opportunity to either enroll on a cellular therapy CAR T with autologous or allogeneic. Patient qualifies for both. How do you choose?
Interesting question, because it's hypothetical, right? I think I would probably let me be guided by the results that we have seen from either of these trials. So when you think about TIL in kidney cancer, people have tried for decades, right, to really grow TIL from these tumors and use that for treatment. So far, that has failed a lot, and we are now seeing some trials there. I have no idea whether there will be responses. Data from the CD70 CAR T cells have shown results, both from Allogene trial, but also from the CTX130 trial. So I probably would go for the allogeneic one because there are more data on that.
Can I ask a question for John as well? So the lack of persistence for the CRISPR therapeutics trial, do you think that was a result of the beta-2 microglobulin knockout? Because I don't know if that same thing was seen in the Allogene trial.
Yeah, I don't know whether that's the case, right? It could very well be that that is the case. We do see in these patients NK cells come up very early. So it could be that these cells are cleared very rapidly because of the fact that there are already NK cells early coming back after lymphodepleting chemotherapy. But it could also be other reasons why these cells do not persist. And I don't think at the moment we have enough idea what is driving this.
I have one final question for the whole panel. So we are looking into these novel therapies and these exciting new mechanisms, and obviously TIL therapy, CAR T cellular therapies, they come at a huge operational expense. So the efforts that goes into this on part of the patient and for the centers also is ginormous. And what we see now are these promising data. There's actual responses now, but all of the data that you report on in the metastatic setting have response rates less than 10%. So in all of you, in your minds, what's the threshold that would actually justify moving something like this forward into a broader clinical space? If we ever get to the space where we see we have a treatment that is so promising and that's tolerable, that justifies going into a registration strategy of some kind, where do we have to be with these therapies in terms of a response rate? Or is it just those few patients who have durable responses? Is that sufficient to you?
I mean, I think it's just this. I mean, I know there's been a lot of work per John's comment about TILs and kidney cancer, but I think it's just the start sort of for cell therapy. But I think the optimism does need to be measured, you know, and a lot of things have failed. I don't think it's about response rate unless that, as you say, unless that response is durable. And we have lifileucel approved in melanoma with a just over 30% response rate, but actually it's about 20% of patients that go on to or seem to have the potential for long-term control. But for them, and I know this is melanoma, not kidney cancer, you know, it does look like that's a potential second shot at cure. And I think the view on that particular treatment is that that treatment is unchanged since the late 80s, early 90s. And so there's room to sort of build on that. So I think it's probably more about durability, but a final comment would be that it's a lot to go through in its current design. You know, it's nasty chemotherapy. It's an inpatient stay of 2 to 3 weeks. This is TIL therapy or most cell therapies, plus or minus having interleukin-2. And it's tough. You know, it's tough to go through for melanoma patients who are actually a pretty fit bunch, to be honest. So I don't know what you think, John.
Yeah, I think you're right. This is not only about response rate, although 10% response rate, even if you have, let's say, a couple of patients having a durable response, is still not good enough to really justify, you know, the setup that you need in order to do this, right? So you would probably want to have at least 20 to 25% response rates, and many of those being durable. But I think we're in kidney cancer, we're still very far from that. So we need more trials, more good targets. And whether that's going to be ERVs or other targets that I didn't mention, I don't know. It's certainly an exploratory field. TIL is completely new in kidney cancer. We have to see whether that translates to a good response rate because you're targeting more than one antigen. In melanoma, it works. In lung cancer, there's clearly evidence, but in kidney cancer, we still have to wait. So I think early days.
Terrific. Thank you so much. Wonderful session. So we are closing, and please join us in the Grenzspursaal for a 20-minute break with the exhibitors. And the sessions will resume here at 11:50 sharp. Thank you.